should be here because you want to hear about the mental health crisis in New Zealand, about what life insurers and health insurers can do to try and bring about more positive outcomes, right? We've got a fabulous panel, who I'll introduce shortly. By now, you know the routine. You should be able to work out how to log lots of questions, and I encourage you to do so with, using the panel we've got. The idea today is about discussing what's needed to support positive change for the industry and for society. And I'm sure we'll get some comments about the state of the respective Australian and New Zealand markets shortly. Briefly want to introduce this panel. Most of them should be familiar to you. First of all, at the far end, Len Elikhis. So Len, of course, is the AIA's Chief Product and Investments Officer. He's a qualified actuary. He's responsible for the design and pricing of AIA's risk and health products, as well as the AIA Vitality Program, which is obviously well-known, well-regarded. And of course, he co-chairs our FSC Health Committee and Data Working Group so wonderfully. So thanks for coming, Len. All the way from Australia especially, and definitely needing to leave at 2:30 p.m. on the dot, is Dr. Rachel David, who is an experienced executive leader and has a track record of producing meaningful outcomes in finance and health and public policy. She's currently the CEO at the Private Healthcare Australia and has held previous roles with Johnson & Johnson, McKinsey, and was the government advisor for the Federal Ministry for Health and Aged Care. So again, Dr. Rachel, thank you so much for your time coming over all this way especially. And of course, finally, a gentleman who probably needs no introduction to you, Shaun Robinson, who's worked in social and health services for 30 years and had a degree of government profile as well in amongst that time, and is now currently the CEO for the Mental Health Foundation. So high intellectual capital, I'm sure you agree. I guess for me, if I start this session rolling, I think here we are in good old New Zealand and the masks are off, and so we can read people's lips again and everything's joy and roses and a bunch of chocolates, right? But so what's your spin, the overall, the crisis, what crisis in terms of society at the moment? Shaun?
Yeah, well, look, I think people often ask me, is there a mental health crisis? And I think the answer is absolutely yes, and it's nothing new. We're in a rolling mental health crisis that has been going on for decades and decades. And I think there are two reasons. It's definitely things like COVID-19 have upped the ante of that. Mm-hmm. And I guess that drives at our understanding of what mental health is, mm-hmm. is core to... Oh, I'm sorry, my phone's going off.
There you are. That's a taxi. One of the three.
Our understanding and framing mental health appropriately is core to actually making some headway here. And I think a big reason why we have not made headway over decades is that we frame mental health exclusively as a deficit and frame it in a way that is actually not true. It actually is not correct to reality. So we tend to frame mental health as an illness. When you say mental health, people automatically think of the negative. You wouldn't say I had physical health last year, meaning I was actually well, but people will often say I had mental health last year, meaning they actually were unwell. So we frame it as a negative. We frame it as some kind of mysterious illness, something that people get somehow and they're broken and then they need to be fixed up by doctors, nurses and medications. Now, I don't want to completely poo-poo that. I live with bipolar disorder. So, doctors, nurses and medications have been very important in my journey. But I think the reality of mental health, the vast majority of mental health issues are to do with what happens to us in our lives, what resources we have internally and externally, and what support we have to deal with those things that happen in our lives. Mm-hmm. So I think COVID-19 has really demonstrated that on a mass population scale. We know that we've had a major disruption in our normality of our lives and that has a big impact on mental well-being. We've been measuring mental well-being against the World Health Organisation WHO 5 scale in New Zealand In the beginning of 2020, a quarter of the adult population had low wellbeing, which is bad enough. At the beginning of this year, it was 36% had low wellbeing. But underlying that, and I won't take the whole day with my dissertation here, but underlying that, we go back 20 years now was the last time that any government did a proper assessment of the mental health need in the community. And back then, 20 years ago, it assessed that 20% of the population in any year would have mental distress that could be diagnosed as a mental illness. Now, by today's population figures, that is 1 million people a year. Mm-hmm. So that is the underlying, that was before COVID, that is the underlying scope of the issue that we're dealing with. And we are simply not going to be able to deal with that traditional view of finding the broken people and fixing them up one at a time. We're not going to address this one at a time. Okay. There are solutions, and I'll come back to more time.
How about you, Dr. Rachel?
Look, again, I would agree that this has been, that we have a number of difficulties in Australia at the moment, but this has evolved over a slower period of time and has been exacerbated by the pandemic and the lockdowns and their consequences. I'm reminding you, in Australia, health insurance is a very big industry. It covers half the population roughly. So I run a peak body that represents the health insurers in Australia, and we cover over 14 million lives in Australia. But the way we're regulated is quite different to anywhere else in the world. We are bolted in to the social insurance program, which is Medicare, as a separate layer. We are not separate from the government insurance program. And that brings some opportunities, but also some constraints on what we can and can't do. We're also community rated, and that means that we cannot alter premiums based on people's health status. Someone coming to a health fund with a mental illness, we can't charge them more just based on their health status. But it's possible that if they were to seek a cheaper product, it wouldn't have mental health cover in it. So that's one of the few ways that we have to manage that risk. The system also effectively locks health insurance out of covering outpatient services provided by doctors. That's seen as being the realm of Medicare and hospitals, and allied health is seen as being the realm of private health insurance. So what's happened is a perverse effect in Australia that you've got an overwhelmed public hospital sector that doesn't want to admit patients. And then you have a private sector where there's a strong incentive for hospitals to admit patients, and there's a lot of cost shifting between public and private, which has put additional upward pressure on costs. We are also dealing with a very significant unmet need in the community, which is driven by a few things, particularly maldistribution of practitioners and a workforce crisis that is spread around the world as a consequence of global workforce, of border closures around the world during the pandemic. So there are very significant shortages of nurses, primary care, physicians and other health workers in the community. There's a crisis in primary care now in Australia as well due to poor government remuneration, which has meant that people are also struggling to see a general practitioner at a reasonable cost. The consequence of that is we've had a 20% increase in claims during COVID-19 for hospital admissions, predominantly for depression, anxiety, substance use disorder, particularly alcohol, and eating disorders, things that could have been predicted, would have occurred as a consequence of the lockdowns. But because of our system, it's very difficult to actively manage those claims and triage those patients into perhaps a more suitable care pathway than direct to hospital. The majority of those admissions were in young women and girls, and it is likely, based on previous statistics, that a very significant proportion of them will come back. So once you've had one hospital admission, 20% of those patients will still be claiming hospital admissions 4 to 5 years later. So that first admission is a strong predictor that patients will come back. And if our goal is to be returned to productivity for young women or young people in their 20s, that is forming relationships, getting into the employment market, getting on the path to owning a home, all of the goals that people have during their 20s, getting educated, travelling, it can be very damaging if someone's entire care pathway is cycling in and out of a low acuity hospital. So there's some of the challenges we have, and I welcome discussion later as to some of the strategies we're looking at to address them.
Great. Len?
Look, I think all of those challenges and trends that we hear about at a New Zealand social level, as well as Australian health funds, are present as well within the life insurance and broader life and health insurance industries. I thought I'd just touch a little bit on some of the statistics, and I would amplify the comment that Shaun made just in the beginning, that this mental health crisis is not new. It has continued, and perhaps it's been accelerated and impacted by the impact of the pandemic, but it is a challenge that the sector's been dealing with for a number of years. Our direct exposure to mental health-related claims is primarily in our disability products, and in particular in our income protection products, where customers receive a monthly income benefit as well as return to work and rehabilitation support while they're unable to work due to illness or injury. Mental health claims has been constantly about 10% by claim count of claims notified. However, they are far more difficult claims to manage. The average length of claim for a client who's returned to work is about 3.5 years. Okay, is about 2.5 years. It's about 30 months, and the average duration of a mental health claim is about 4.5 years. So we're talking about very complex, very long-term claims. And so if we actually look at the overall claim amounts that are paid, even though it's only 10% by count, it's about 25% by dollar, just behind musculoskeletal related claims, which is often what people think about when they think about insuring themselves for income protection. Aside from the direct costs, though, of specific mental health related claims, there's very strong evidence all over the place, including in New Zealand, that people who experience mental health challenges or mental health distress also suffer from a range of other increased risk factors. So, for example, a much higher rate of heart disease, more likely to have to be carrying a higher level of weight, and so there's all sorts of muscular conditions as well. And so that then leads indirectly to a cost to the overall health system, so in terms of health insurance claims that are paid. And ultimately, in very extreme examples, for people who suffer from extreme distress, it presents as self-harm claims under our life insurance. So it is very significant, it's very complex, but also there are opportunities to manage it. And I think that as a government, as employers, as a sector, all of us have pretty strong incentives to try and address it. And I'm looking forward to discussing some of that today.
In the session next door, we just heard about the FSC's financial resilience indexing, and there was a lot of talk there about the cost of living and the impact of the cost of living pressures on people. Is there anything that you're seeing currently that's more specific to the economic volatility and cost of living rather than pandemic per se?
Look, I can speak for Australia, and that is that if you have a mental health condition, particularly if it is in one of the categories that I mentioned previously,
yeah,
or it's in the alcohol and other drugs, or the substance use disorder category, the great majority of treatment occurs in private.
Yeah.
It's very difficult. In fact, I had a psychiatrist who worked in a major public hospital that sees a lot of homeless patients and people with severe challenges in a metro area. He said to me, look, unless you're homicidal, you will not get admitted as a mental health patient to this facility. And he was not joking. There's huge cost shifting to the private sector, and to purchase products for the ongoing treatment, which cover the ongoing treatment of of mental illness, you're looking at very high premiums, top hospital cover. The wait times have almost been eliminated, so that's another factor that plays into it. The alternative is out-of-hospital care pathways, which we're hoping to develop more and get more regulatory approval for. But at the moment, they come with some very significant out-of-pocket costs, which patients try and avoid. So at least if they've got top hospital cover, their costs are predictable. Whereas with the out-of-pockets for out-of-hospital care can be unpredictable, and there is quite a long wait for appointments, even in private. And a number of government strategies that have been put in place to address this have just increased demand. They haven't increased supply of workers
Services,
or
yeah.
services.
Yeah.
So yeah, it is a big impulse for people to deal with cost of living pressures.
Sure.
Yeah, I would add that, as I said, the fundamental driver of poor mental health and poor well-being is things that happen to you in your life and the resources and support you've got to deal with those things. And the cost of living pressures, in fact, in England they're calling it a cost of living crisis.
That's right.
That's flowed on from the pandemic, will definitely be increasing the stress and pressure on many vulnerable people in the community, and that will undoubtedly be having a flow-on effect into mental health. Very, very practical. I spoke to a young woman a few years ago, and we were talking about, the social determinants of mental health, and she said, yeah, it's absolutely real. I struggle with depression, have done for many years. Last year I was working part-time, I was living in overcrowded, damp housing, I was always worried about paying my bills. I became suicidal. This year I've got a better job, it pays better, I can live in a better house. I still have periods of depression, but I'm not suicidal. It's really that simple.
Yeah. Len, in the data you've been talking about, is there anything that your customers have been saying, anything that's alerted to you to gaps in the product offering?
Yeah, I think probably the immediate, area of focus for us and some feedback that we've had, and it relates to a point that Rachel made, is just around supply. So we spent about $1.5 million a year on rehabilitating claimants and getting them back to work, which is really important for their health and well-being. And about $1 million of that $1.5 million is spent specifically with the 10% of mental health-related claims. Prior to COVID, it would take us about 2 to 3 weeks to be able to schedule an appointment with a psychologist or psychiatrist for a claimant. At the moment, we're looking at about a 4 to 6 week wait. And so that doesn't sound like a lot, but those additional 2 to 3 weeks is pretty significant when you think about the ability to intervene with someone early in order to be able to put them, get them onto track, put the support around them that they require so that they can start on a path towards recovery. So I think one real area is, as we think about an increase in funding, which is absolutely important, also has to be a very long-term strategy about how we increase the supply of mental health related services.
Yeah.
And in particular, I guess, in terms of insights from data, what we're wanting to do is we're wanting to be able to provide some support built in within our products, within the services that we offer, that come in before a person needs to make a claim. And so in the preventative space, potentially at-risk groups, I think as a sector, subject to being able to secure access to psych services, we're good at helping people return to work, but there's a whole large percentage of the population who may never claim, but who nevertheless require support.
I want to deviate a little for a moment because I'm reminded of that Consumer New Zealand article that cropped up during the year, and we talked about this in one of our FSC committees. But the role of data keeps cropping up in this conversation, and you were talking about some research on data you've been doing, Shaun. What's the position? How well off are we as an industry in terms of the evidence and the database that we've got to deal with situations that arise which paint the industry potentially in a black light? And I'm thinking we had a presentation from the Australian perspective based on some KPMG data that came out in 2021. And if I'm right, it was because of that data that it helped the industry defend against some of the accusations being made against the industry, particularly in regards to discrimination. Have you got any comments on the position we're in here in New Zealand? And maybe it's the Australian experience as well.
I'd maybe come at that from a slightly different angle.
Yeah,
And
yeah.
number one, I would say I love insurance companies. And the reason I love insurance companies is insurance companies get prevention. So, I think in terms of data, I would come from that bigger picture population level. And just as a bit of a reality check, it's about 60 people in this room. About 50 of you will experience some level of mental illness during the course of your life. We know that from longitudinal studies. About probably 25 of you will experience some very significant mental distress this year. Probably about 15 of you are experiencing it right now. It's current in your lives right now. So, this is not about other people, this is about all of us, because our mental distress, our mental health is about what happens to us in our lives, and we shouldn't be surprised that we're going to have times of mental illness or mental distress, just as we are not surprised that if we went our whole lives we'll have times of physical ill health. So I think from that perspective, then I think there are several approaches, and I know AIA, I know Southern Cross, I know Farmers Mutual Group, FMG, have all leaned very heavily into prevention, into how do you keep your client base well, but also how do you keep your own staff well, and how do you keep the community of interest that you draw your clients from well. So FMG has been a key partner in FarmStrong. We've worked with AIA, Southern Cross has resourced a mind health program in schools. We've worked with Southern Cross on internal training programs. We've worked with ACC on internal training programs about how to keep their own staff well. So I think, if I was to encourage anything in the industry, it's to think at a population level. Sure, when it comes to people insuring themselves individually, we're talking about individual claims and obviously individual treatment. But I come back to the fact we are never going to solve the mental health problem one person at a time. Yeah. And the big contribution you can make to your own business success is to keep your members well and keep your communities well.
How about the organisation itself? So one of the things we discussed in the pre-brief was about the role of employers contributing to organisational well-being and mental health well-being of their own employees. Dr. Rachel, we talked about this. Yeah.
Yes, and look, I think this is an incredibly it's a very common topic around the world about the extent to which employers should take some responsibility. In Australia, unlike the US, there isn't a strong basis for employers taking out insurance or paying for insurance on behalf of their members. That's something that either the individual does or the government does, but there's not a lot of employer interest. But that being said, I think global trends have definitely picked up, and employers are considering this more and more. Look, I have personally, as a leader in a number of businesses, managed people with some quite severe mental health conditions. Sometimes, that went smoothly. In a couple of occasions that I still keep me awake at night, it most certainly did not. And those tended to occur when I was a younger manager and when things perhaps 15, 20 years ago were a lot less sophisticated in terms of responses to these things than they are now. I'm not of the belief that an employer can take responsibility right down to the level of the individual in all cases. But I do think there are some things that overall, that there's some data about that they can do on, because the population level data does support it, that they can do to make their workplace safer. And I'm thinking about things along the lines of having a strong anti-bullying policy and strong and complying with OC health and safety regulations around things like fresh air and ability to exercise and safe working hours.
Yeah.
You know, these are important things. You know, I once worked for one of the management consulting firms that had a culture around long working hours with no exercise for younger individuals, which as an older person coming to that, I'd already had children by the time I came into that environment, I just refused to comply with. And there was no difference in the quality of my outputs. So, you know, that's the sort of thing that I think, you know, needs to be proactively addressed. And that sort of cult-like work environment really produces the kind of outcomes that that people that are in the bubble tend to think. So I think there are certainly some risks there, and there's been a very high-profile case in the media in Australia just recently about a suicide that occurred in one of the accounting firms after a night of, you know, which had a culture around like working through the night on audits, and the suicide occurred after a big drinking event, you know, in the city. And so there were a number of unsafe practices that had gone on that became very public. So I think that there are steps that can be taken to address all of those things. Flexible work is another one, but again, we have to be careful. I think it was really clear from the data during the lockdown that, you know, flexible work is fine, but what if the person's locked down in a toxic home environment? And so having a policy around domestic violence and coercive control is another area which is particularly important. We're seeing a number of our funds get involved in that area at the moment.
Len, did you want to add? No?
Oh, look, I'd just say, you know, the three key stakeholders that have, if we look at it very clinically, that have skin in the game, are governments in terms of the financial costs of, you know, caring for people and just generally, you know, well-being and social cohesion. You've got employers who wear the cost of poor health outcomes, whether they're mental health outcomes or physical health outcomes. You know, that presents as absenteeism or presenteeism, you know, the challenges to productivity that Rachel talked about. And then ultimately, I think for insurers, there's obviously, you know, long-term cost to poor health outcomes, again, whether that's mental health or physical outcomes. And we often talk about the sustainability of insurance, and one of the things that so significantly undermines the sustainability of insurance is the fact that we are living longer, but we are not healthier, and there is a cost to that. So I think all three of those entities have a role to play, and I'd love to see more collaboration. You know, in Australia, as Rachel mentioned, you know, there's pros and cons, but the private health system and the public health system tend to be a little bit better integrated. Here in New Zealand, we're relatively at arm's length, we're relatively apart from one another. There are some points of connection, but broadly, you know, if you've got a private health insurance policy, then you're going to get this care, and if you don't, then you're going to get the public care, and the level of interaction and the opportunity to kind of have a seamless New Zealand-centric view of things is a little bit more limited. So yeah, that's probably my only point, is I'd love to see this tackled in a much more systemic, much more organised way, with very thoughtful connections made between the employer, the government, and insurers.
Let's go to systemic shortly, but Shaun?
Yeah, I was just going to say, yeah, I'd love to see it tackled in a systemic and organised way as
Yeah.
well. Been waiting for quite a long time. Yeah, I just really wanted to pick up from the workplace perspective and pick on something that Rachel said about making workplaces safe. And, you know, in many ways, I think a workplace is one little population. A whānau, a family is another, a community is another, a school is another, and a whole society is another. And you know, we at the Mental Health Foundation, and this is based on ample research, actually mirrors what the inquiry into mental health and addiction said, but we describe the solution as being the intersection of three things. Yes, make any level of these kind of populations safe. So yes, make your workplace safe, make it not be doing damage to people's mental and emotional health, but also make it strong. So, and this is about building up the behaviours, the interactions that have a scientific basis in increasing our mental health and well-being and our resilience. And I can give you some data about that in a minute if there's time. So safe, strong, and then yes, supportive, that even if we get safe and strong right, things happen in people's lives. You experience grief and loss. You might have times of physical ill health, financial challenge, whatever, relationship changes. There will be times when people need support, and both informal support, the support of our colleagues, friends, and the formal support of services needs to be appropriate. Now, the trouble, going back to my opening statement, is that for decades we have only concentrated on the support end of things, and we seem to sort of think if only we did more of that we'd get a better result. And actually the definition of madness is to continue to do what you've always done thinking you'll get a different result. It is the intersection of support, strong and safe, that will create a turnaround in the crisis. And you can do that in a microcosm within your own workplace as well as the macro societal level.
The thing that struck me, we were gifted to have a presentation from Rob McGrath, who's the CMO of NIB, thanks to Dave and a few on our committee, remember, and it stunned me that the $11 billion of Australian money goes into mental health services in Aussie each year. But what's the outcomes? How much of that is actually just a cost shuffling type of exercise in your opinion, Rachel?
Look, I do think that the allocation could be better, and I think that we struggle to provide effective services to outpatients, particularly in the areas of anxiety, depression, personality disorders and eating disorders and alcohol and other drugs. There's a strong bias towards inpatient care, which is more expensive. And then at the other end of the spectrum, people with very serious conditions like schizophrenia, who are non-verbal, who might live on the streets, struggle to access services in the public sector. So there's a strong bias towards a certain type of care, which is inpatient, which is low acuity inpatient care, which is expensive to provide, but where the outcomes are equally as good in a cheaper setting. So we're trying to push for a reallocation of those dollars, but the way our system is constructed, it strongly incentivises in-hospital care in a private low acuity setting.
Yeah.
And I'll give you an example. I was recently at Bupa, which is a big insurer in Australia, and I was talking to a young lad there whose friend has depression, had it for many years, was well managed, but had an exacerbation during the COVID lockdowns. He was admitted to hospital for a standard 3-week course of treatment, barely saw a psychiatrist the whole time he was there. It was just a brief telehealth interaction, and was taken for yoga and group therapy every day, maybe had some medication adjusted. Now, there's no reason why that level of care for someone who wasn't actively self-harming couldn't have been provided at home. If his home was a safe environment, someone could have visited him and taken him for the yoga and exercise session and for group therapy, and in fact even provided more coaching and effective interactions in the community, like going to the local coffee shop on the way and so forth. But we seem to be locked into this cycle of spending money on low-value hospital admissions, which encourage a dependence on hospitals, because the hospitals are building more beds and they want remuneration, for these patients, their strong resistance to change.
Yeah.
With the workforce challenges in outpatients, it's going to take time, but we are actively investing in more preventive mechanisms and models of care which do provide solutions in outpatients, including for alcohol detox, actually, which I think is quite important. There's no reason why with medical supervision that you can't detox at home unless you have a history of delirium tremens with seizures. You can detox safely at home under medical supervision, and yet the default is admission to hospital. So we're trying to both educate primary care providers and educate consumers better and provide more preventive services to people so they can avoid these high touch but low value pathways.
Yeah. Because in New Zealand, you might be able to give us an update, Shaun. Didn't the government put aside, was it 2 billion a year or 2 or 3 ago?
1.9 billion.
1.9, that's right. So how's that being allocated? And yeah, so let's start with that. What's happened?
I get a wry smile
Oh,
because
dear.
no one can tell.
No one can tell.
Yeah, I mean, look, what I say often in the media, I think if I give my thumbnail sketch, I think the government came in quite sincerely wanting to do something about mental health, but also quite happily exploiting the fact that they got a lot of votes by saying they were going to do something about mental health. I think they had no idea the scope or scale or nature of the issue, and it scared the bejesus out of them once they found out what it was they promised to do. Then they threw a number, 1.9 billion. Where did that come from? I have no idea. Probably just what they thought they could afford. They threw that at the problem. At the time that they did that, I've seen the cabinet paper and it said we've accepted 38 of the 40 recommendations of the inquiry. You must have an implementation plan because it's a complex set of changes. We are now nearly 4 years on from that. There is no implementation plan. And again, it goes back to framing. What the government did was, regardless of the fact that the inquiry had actually said this is not just about more services, it is about creating a safer New Zealand, creating a New Zealand where people, where well-being behaviours and activities are promoted and providing more services. The government immediately just went to the same old, let's put the money into more services. Yeah. Now, you can pump as many $1 billion as you like into services, and you are not going to touch the sides of this issue. Where has that money gone? They can't tell you, quite frankly. I do always say in the media, everything the government has done is good. They just haven't done enough, and they have not, and they've been, they haven't been systematic. So they have created new early support services at a GP level, and there are now, several 100,000 people that have benefited from that. Which is very much along the lines of what Rachel was saying. It's difficult to get going in Australia. So that is a very positive move. But again, it's still at the end of let's wait till people are really struggling and then fix them up. That will always be needed, but unless we actually equip all of us, you guys included, with the skills, the behaviours, the understandings, the mutual support to be able to cope with the ups and downs of life, and we make that part of the culture of how workplaces, schools, communities operate, we will never, ever solve this issue.
So the role of the financial services as an industry, any observations or comments about that?
Yeah, look, as I mentioned, we've got a strong financial incentive to try and improve all health outcomes, including mental health outcomes. Just as an example, as a data point, we're doing some work at the moment within our Vitality program, which to date has primarily focused on physical health and well-being, but also recognising that good lifestyle behaviours also contribute to good mental health. So good physical activity shows to be an effective control and effective treatment for people with low-level depressive disorders. Sleep is a really important determinant of good mental health because it affects you systemically, physiologically. Good diet's important. If you're eating, very high refined carbohydrates, then you go through this sort of cycle of boom and bust in terms of energy. So we've done all of that, and we continue to invest in that. But we have now done some work to try and incorporate some mental well-being modules to the program as well, in order to be able to use a clinical approach along the lines that Shaun described, to be able to try and intervene with people early and to encourage the right sort of behaviours and patterns of action that reduce the risk of an onset of mental distress. So our modules kind of look at it as learn, act and chat. The learn is really just about empowering people with giving people information to understand what good mental health looks like and what some of the trigger points are for recognising when you need support, but also when you might be able to take some behaviours to improve your mental health. So that's learn. Giving people information is nice, but it's not enough. ACT then is about helping to build little rituals that people can undertake in order to be able to take take the right actions to improve the mental health outcomes. So, that's things like gratitude journaling. So encouraging people to take time and reflect on things in their life that are positive. Things like mindfulness that have a really strong clinical foundation to improving resilience. Things like helping people understand how their energy levels and how their mood varies according to whether they've exercised or the number of hours of sleep that they've had, of what they've eaten. And then finally, on the chat side is really for people who require support along the lines that Rachel described, not people at the point of crisis, but all of us in just our daily lives, from time to time, we feel down, from time to time, we need some support. And so to have a connection into some app-based chat with an appropriately qualified person just to be able to help get them back on track. Yeah. That's just one example of one company, but I think, as you mentioned, Troy, and Shaun, there are other organisations that are doing things, and I think the investment into prevention, and especially if it's grounded in clinical fact, I think can really deliver a lot of value, which is disproportionate to the cost.
This digital innovation and the integration of digital seems important to me. I bet this fintech, everything's going digital. But is there any evidence or any comment you want to make, perhaps Dr. Rachel, about the integration of digital into broader health care?
Yeah, there is.
Yeah.
And, if anyone who's spent any length of time on TikTok or Instagram will also know there's a lot of rubbish out there.
Yeah.
But, I think everyone, if you looked at TikTok, everybody in this room would have ADHD. But, really, I don't mean to be cynical, but, there are some very good evidence-based programs that integrated into a complete strategy have some strong evidence behind them and are actually pretty effective. What they don't do is replace a properly run, a properly integrated mental health system, but they do have some strong basis in just educating people about the basics as well. Like we still have people in Australia who've been admitted to hospital because no one's taught them rebreathing techniques to circumvent a panic attack. We have people in hospital because they've become distressed after a relationship breakdown who have no history of anxiety or depression and will go on to be completely fine. I mean, these are things that can be prevented by early intervention. The issue is that, there needs to be a proper escalation plan if it's not working and someone does need help, and that does need to start with a face-to-face consultation and a proper diagnosis at that point. I don't think you can just go straight to app to telehealth whatever. It does, once you get to the point where it's clear that help is needed, then you absolutely need the right diagnosis. Otherwise, that does expose the patient to risk to themselves, but also possibly going down the wrong path and getting on a hamster wheel of interventions that are incorrect and that they can't get off.
Fantastic. Hey, look, we've got a flood of questions, and I'm noticing we've got about 15 minutes left, so I might cut over to the things that have been coming from the floor. And I know you have to get away at 2:30. So thanks very much for sending these up. There is a flood all of a sudden. What proactive steps should insurers take to be able to continue to offer mental health coverage at a fair price to as many customers as possible? That's probably one for you, Lee.
Yeah, okay. Well, I think there's a couple. So I think, firstly, what we want to do ultimately is reduce the incidence of mental health related claims. And to do that, I think you need to look at clinically based interventions and invest in that. I think that's really important. We have to actually address the underlying incidence rates. And then on the other side of it is kind of reducing the severity of the claims once they arise. And rehabilitation support is one component, and I think is a very important component. For us at AAA, we usually insist that people do meet face-to-face with a psych as part of that initial consultation. There's just so much that can be gained from that in-person interaction, and then a plan can be put forward that's appropriate to the individual. I think investments into those sorts of services are important. But I think it's also really important to kind of recognise that, that overall, the kind of the costs of mental health are borne by society at large, and I think what we ought to do is seeing whether we can better connect with the government and with some of the government's initiatives in order to be able to also just kind of address the impacts on NZ Inc. The New Zealand income insurance scheme is a really great example of extending coverage to the entire population, and also will create a huge amount of funding that then becomes available to provide mental health support services. But what really concerns us at AAA and the sector more generally is just making sure, that the patient care, that there's a continuity in the types of services that people can receive as they move from the scheme towards a claim with the insurer. And it's really important to focus on that. We would really love to see that sort of strengthen in some systemic way.
And Rachel, there's one here. How do you provide support and care in a rural environment against urban, especially with access to medical specialism being perhaps less available in those rural areas?
Well, look, it's a big challenge in Australia where you've got big distances and a culture where affordable travel is becoming a real issue. As you know, in Australia, we have not really invested much in rail, so you've either got to drive or fly around everywhere in planes, which is at the moment becoming very expensive with fuel costs. There's also a tendency for people with long-standing mental health conditions to move to and reside in regional areas which are quieter, cheaper places to live, but have far less access to services in some cases. So perhaps as a fortunate consequence of COVID, a lot of psychiatric services have moved to telehealth. But, and I think that's a good start. But again, I do stress that initial face-to-face contact for diagnosis does need to be funded. Yeah. And some health funds will, particularly those located in the regions, will provide support for transport and accommodation for that purpose. But also, comorbidities is a big issue, and strong support from local primary care. And this is where the government's investment in primary care is important. So if a person does have concurrent or or physical conditions that are a consequence of their mental health issues, then they need to be treated as well, and as does substance abuse disorder, which often coexists.
Shaun, this one's been targeted at you. I think we might have covered it, but what role do you think, or would you like to see private health insurers playing more in terms of providing cover and support to their customers for mental health? And are they doing enough already? And there's media in the room, possibly.
Yeah. Look, I think I won't go down the rabbit hole of discrimination, because I think that's a whole nother area.
It is, yeah.
As I said before, I think there's a massive underinvestment in prevention and an underinvestment in what I would call a sort of population health approach as opposed to an individual sort of clinical approach to mental health. We need the individual clinical approach, but that's where, and that needs to be reformed and the models need to change, but we absolutely need to invest in that population level approach. When we did the research into the WHO-5 and low wellbeing score at the beginning of 2020, we also looked at 12 different behaviours. Len talked about the ACT component of their model. We talk about behaviours or habits or lifestyles. We looked at 12 different behaviours that have an evidence base to improve your mental health and wellbeing. And these include things like connecting with other people. They include things like things that build up a sense of your cultural identity or your sense of who you are, through exercise, through eating well, through keeping your mind open and active to new things. The really interesting correlation, we looked for what was the common factor for people in that 25% with a low wellbeing score. I was fully expecting it to be a cultural thing or an income thing. The absolute overriding commonality was that people with a low well-being had not one of those 12 activities in their kind of routine daily life. And on the hope side, conversely, just one of those behaviours gave you a 48% higher chance of having a positive wellbeing score, and it was cumulative. So the more of those behaviours you had incorporated into your habitual lifestyle, the higher your wellbeing score, and that overrode things like poverty, ethnicity, and in fact Māori, interestingly, who are up against it in many social conditions, had on average a higher wellbeing score, and one of the correlations there was that they were much more involved in things that connected them to friends and family and connected them to a sense of their cultural identity. So invest in those things.
Do you have any thoughts about how an insurance industry can encourage customers to seek help for mental illness issues when they fear subsequent underwriting implications? Who wants to challenge that one?
Well, I mean, we only underwrite once, so I think once the cover's in place, then there's really an incentive to ask for help, because we're not going to apply terms or loadings or anything like that onto a thing. But I think kind of generally that there does seem to be a kind of a level of misunderstanding about the role of insurers and the role that we play, and our preparedness to individually assess customer applications. So I think we probably need to do a better job as a sector actually educating consumers about kind of disclosure and the role of insurers more generally. But for us, and we often talk to advisors, and the first and most important thing we encourage them to do is tell people that if they're having a crisis, talk to the insurer straight away. It's much better for us to start offering rehabilitation early than leaving it to develop, waiting for the end of the waiting period before you can begin, because just the outcomes are so much better if you can seek help early. And that's true actually regardless of whether you have insurance or not. Reaching out and getting support early is really important.
I've got time for probably two quick ones. This one, Rachel, has been directed to you. How vital is the early intervention? What's that early window look like? How long is it in terms of helping people with mental illness symptoms?
Look, I think it does depend on the condition. And there are some good stats around, and one is that one of the really important factors is if someone's admitted unexpectedly to hospital in an emergency situation, such as threatening self-harm, it's really important that the first intervention that takes place is that someone actually calls them once they've been discharged to see how they're going, and to check in with them and ensure that they're following the plan. You'd be astonished about how often that does not happen, and someone's just thrown back into the ether, and the follow-up doesn't take place, or there's a miscommunication with primary care. So there's strong evidence that that needs to take place. The other issue is, of course, are we reaching the right people in society in terms of prevention, which is something like, we're often accused of, kind of providing a lot of services to the worried well. And I do think that's an issue, and how we perhaps reach some groups that never engage easily with health insurance or with the medical profession is a challenge that we need to face up to. I don't think it's it's not a coincidence that it's young women that are predominantly coming forward for treatment. We've got to think a little bit about young men, and young men who are in trades and traditional blue-collar occupations that, it may not still even today be at all acceptable to acknowledge that you have issues. And how we reach those groups, that may be a greater role for employers in that particular circumstance, because that group certainly does not engage with insurers.
Great answer. This one, final one, probably targeted more to our Kiwis. Do you feel the presence of non-ACC offset disability products incentivises people on primary non-mental health claims to stay on claims for longer for mental health reasons? Is product design part of the problem of conflating mental health claims?
Look, I know that's often a concern that's cited, but to be honest, the portion of people who use the term malinger on a claim, that is to say that they've made a full recovery and just decide that they want to continue to collect a benefit, are really, really low. It's a pretty insignificant component, and the reason we know that is because we invest, as insurers, we invest a lot of time and energy and effort and money into rehabilitation. And so we get pretty good case notes from treating specialists about how people are going in terms of their recovery. So absolutely, I think product can create certain financial incentives that might encourage people to remain on claim perhaps longer than they might otherwise like. But I think most people want to get back to work. Work is a really important part of our overall health and well-being. It's a form of social connection for a lot of people, and I think most people just kind of want to get back to living their life. I think really, the challenge around product design is really just making sure that, it's not just the contract, but also, all of the support that's wrapped up around all of the rehabilitation, return to work types of services are very much geared towards returning the person to being able to return to work rather than creating codependence on the treating psychiatrist or psychologist. And that's probably the key thing.
So to wrap up, we've really only got 40 seconds each, but I'm handing you the baton of creating world peace, ending wars, everything. If there's one thing that you can recommend to the audience in terms of what they should change in their business or what you'd like to see change for the improvement of mental health and well-being, what would it be?
Encourage all your clients and their communities to have lifestyle habits that have an evidence base, improve their mental health and well-being. You'll save money, they'll live better lives.
Great. Rachel?
Change the incentives, and this is government as well as funds, change the incentives towards out-of-hospital and preventive care where appropriate.
Great.
I'll go two. I think one is that everyone should jump on the Mental Health Foundation website and look at the 5 ways to wellbeing and familiarise yourself with those and incorporate some of those little rituals into your daily life. That's one. And the second one is really just a plea for better coordination and integration between the government, employers and insurers in relation to managing mental health.
So thank you all for attending this session, folks, and extreme thanks to Dr. Rachel coming all the way from Australia for this session. Thank you so much. To Len, of course, coming away from another event that you've been at, and Shaun, who went through 3 taxis to get here. Thank you all so much for your intellectual capital and providing your insights to the audience today, because we showed them the usual way of thanks.